Picture this: a patient walks into your consulting room. 58 years old, type 2 diabetes, eGFR of 55, already on an SGLT2 inhibitor, on metformin, HbA1c hovering around 7.8, and the question you get asked every single week: "Doc, should I be on one of those weight loss injections? My neighbor lost 15 kilos on it."
Good morning. It is Thursday, the 13th of August, 4 stories today, and that patient scenario is exactly where we start, because we finally have a definitive answer on what semaglutide does to the kidneys, across the full cardio-kidney metabolic spectrum.
Story 1. Semaglutide and kidney outcomes. A pre-specified participant-level pooled analysis of 3 landmark trials, SELECT, FLOW, and SOUL, published in Lancet Diabetes and Endocrinology on August 7th. Over 30,000 participants pooled, and the headline number: a 16% reduction in a composite kidney outcome. That is persistent 50% eGFR decline, kidney failure, kidney-related death, or cardiovascular death.
Hold on, 16%. That sounds modest. Break that down for me. Is this clinically meaningful, or is this statistical window dressing?
Fair question. When they stripped cardiovascular death out of the composite, the narrower kidney-specific outcome dropped by 20%, hazard ratio of 0.80. That is a real kidney signal, not just fewer cardiac deaths. And remember, these patients were already on standard of care, many of them already on ACE inhibitors, SGLT2 inhibitors. The benefit was on top of all of that.
Who was in this pooled analysis exactly? Because SELECT was obese patients with cardiovascular disease, FLOW was diabetic kidney disease, SOUL was type 2 diabetes with CV disease or CKD. These are quite different populations.
That is the strength. 30,787 participants across those 3 trials. Mean follow-up of 40 to 48 months. The benefit was consistent regardless of baseline characteristics, with diabetes, without diabetes. The AU connection matters here too. Vlado Perkovic from the George Institute in Sydney is senior author. This is not industry spin. This is independent Australian academic leadership analysing the data.
But all 3 trials were funded by Novo Nordisk. That always raises an eyebrow.
True, industry funded, but the analysis was pre-specified, participant-level data, not just a literature meta-analysis, and the direction of effect is biologically plausible. GLP-1 receptor agonists reduce inflammation, improve endothelial function, reduce albuminuria. We already knew FLOW showed a kidney benefit in diabetic kidney disease specifically. What this pooled analysis adds is the signal extends to the broader cardio-kidney metabolic population.
Let me play devil's advocate. What about the adverse events? We know GLP-1 receptor agonists cause nausea, vomiting, diarrhea. Those are not trivial in a renal population where volume status is already precarious.
The safety profile was consistent with the class. Gastrointestinal adverse events, as expected, but serious adverse events were numerically lower with semaglutide than placebo. No new safety signals. The authors are clear. The benefit-risk profile is favorable.
So for that patient in the opening scenario, 58, diabetic, eGFR 55, already on an SGLT2 inhibitor, what do we actually do differently tomorrow?
This is the paper you take to your next practice meeting. If that patient has cardiovascular disease or risk factors, and you were already considering a GLP-1 receptor agonist, the kidney data strengthens the case. We are not just managing glucose or weight. We are protecting the kidneys, and oral semaglutide from the SOUL data also contributed to this signal. So even patients who prefer oral to injection get the kidney benefit.
That is genuinely practice-changing. Not a miracle, not curative, but a meaningful, incremental kidney protective option in a population that has very few. Let us move to story 2, a completely different domain: chronic cough in idiopathic pulmonary fibrosis.
Story 2. Oral Nalbuphine for IPF-associated cough. The CORAL trial, published in JAMA, 165 patients across 52 sites in 10 countries. This is the first effective pharmacological treatment for what patients consistently rate as their most distressing symptom.
Before the numbers, why is IPF cough so hard to treat? We all have patients with this.
Because the cough mechanism in IPF is fundamentally different from a typical cough. It is not driven by airway irritation alone. There is peripheral sensitization of cough receptors in fibrotic lung tissue, central sensitization in the brainstem. Opioid receptors, specifically the Kappa receptor, are involved in cough suppression, but traditional opioids hit the mu receptor. That gives you the cough suppression but also the respiratory depression, constipation, and addiction risk. Nalbuphine is different. It is a Kappa agonist and a mu antagonist, so you get the cough suppression without the classic opioid side effect profile.
Interesting mechanism. Now give me the actual trial results.
The primary outcome was relative change in 24-hour cough frequency measured by a digital cough monitor at 6 weeks. Placebo reduced cough by about 17%. Nalbuphine at 54 mg twice daily reduced it by 53%. At 108 mg, 60%. All 3 doses were statistically superior to placebo for the objective cough count.
60% reduction in cough. That is a large effect, but this is a phase 2b trial. 6 weeks of treatment. What about durability? What about safety over months or years?
Those are exactly the right limitations. 6 weeks only. Phase 2b. Phase 3 trials of longer duration are needed. The population was predominantly white, median age 71, but for a condition where the standard approach has been simple linctus and sympathy, this is a genuine breakthrough. The 2 higher doses also improved patient-reported cough frequency, not just the objective monitor. That tells us patients actually felt the difference.
Nalbuphine is not exactly a household name in Australia. Where does it sit in our practice?
Nalbuphine is available in Australia as an injectable opioid analgesic, used occasionally in obstetrics and perioperative care. The oral extended-release formulation used in CORAL is not yet TGA approved for this indication. Trevi Therapeutics is developing it specifically for chronic cough, so this is not available tomorrow, but it represents proof of mechanism, and it tells us that Kappa-opioid receptor agonism is a viable target for refractory cough. cough. For your IPF patients right now, it means a treatment pathway is coming. For patients with chronic refractory cough more broadly, the Kappa receptor story may eventually extend beyond IPF.
Good. Something to watch. Let us shift gears completely. Story 3 is for the obstetrics discussion. Tell me about the Seminal Microbiome paper.
Story 3. Gut, vaginal, and seminal microbiomes in couples with infertility or recurrent pregnancy loss. Published in Lancet Obstetrics, Gynecology and Women's Health. Danish study. 353 women and 191 male partners. 2 cohorts, 1 undergoing IVF or IKSI, 1 with recurrent pregnancy loss, and the finding that has everyone talking: seminal dysbiosis.
Define seminal dysbiosis for our listeners. What exactly did they measure?
They used deep shotgun metagenomic sequencing to profile the bacterial communities in semen. About a quarter of the male partners had a bacterial profile in their semen that resembled the pattern we associate with bacterial vaginosis in women. They called it seminal V dysbiosis. The key finding: among couples undergoing IVF or IKSI, if the male partner had this pattern, the live birth rate was 57%. If he did not, it was 85%. That is a 28 percentage point difference.
57 versus 85. That is a massive difference. But I have to push back hard. This is observational. 2 cohorts, no randomization, no control group of fertile couples, and they did not prove causation. They showed association.
Absolutely right. The authors are transparent about this. They did not establish mechanism. They cannot say the bacteria caused the pregnancy loss. It could be that whatever causes infertility also alters the microbiome. Reverse causation is a real concern, but the consistency across both cohorts, IVF and recurrent loss, is suggestive.
And the female gut microbiome finding, what was that about?
Women with greater gut microbial imbalance had lower chances of conception and longer time to pregnancy, but interestingly, gut dysbiosis was not associated with miscarriage, and the vaginal microbiome showed no consistent association with outcomes, so it is specifically the semen bacteria and the female gut bacteria that carried the signal.
What is the mechanism? How would bacteria in semen affect implantation or early pregnancy?
The authors hypothesize it could be through inflammation. Semen contacts the female reproductive tract during intercourse. An altered bacterial profile could trigger an immune response that affects implantation, or it could affect sperm function directly through oxidative stress, but these are hypotheses. The important clinical point is this: a man can have a completely normal semen analysis, normal count, normal motility, normal morphology, and still have this bacterial imbalance that standard testing cannot detect.
So what do we tell patients tomorrow? Should fertility clinics start doing semen microbiome testing?
Not yet. Microbiome testing is not part of routine fertility assessment. The authors explicitly state that larger clinical trials are needed before this becomes standard care. But this study changes the conversation. It tells us the male partner's microbiome matters. It reframes infertility assessment from a female-focused workup to a couple-level investigation. Tell your wife about this one, because this is the kind of finding that will drive the next wave of fertility research.
It also connects thematically to what we are seeing across medicine. The microbiome is not just a gut story anymore. It is everywhere. And we are only beginning to understand it. Let us close with story 4, something every GP deals with every day: smoking cessation.
Story 4. The first clinical guidance in the United States on using e-cigarettes to help adults quit smoking, published in JAMA on August 12th. A special communication from the Society for Research on Nicotine and Tobacco, 24 tobacco treatment experts, and the single overarching recommendation: clinicians should include nicotine e-cigarettes on the menu of options when discussing smoking cessation with adult patients.
This is going to be controversial. The AHA and the American Lung Association still tell patients to avoid e-cigarettes. And in Australia, e-cigarettes are heavily restricted, prescription only since 2021. Where does this guidance leave Australian practice?
You are right that the Australian context is different. E-cigarette availability has been severely restricted, but the evidence base the authors cite is universal. A Cochrane review of over 100 studies and 30,000 adults found nicotine e-cigarettes were more effective for smoking cessation than nicotine replacement therapy, comparable to varenicline. The key message is about harm reduction. For an adult who smokes, the relevant comparison is not e-cigarettes versus nothing. It is e-cigarettes versus continued smoking, and combustible tobacco kills half of long-term users.
The EVALI outbreak in 2019 is the elephant in the room. How do the authors address that?
Directly. They point out EVALI was caused by illicit cannabis vaping products containing vitamin E acetate, not by nicotine e-cigarettes. That distinction was lost in public messaging. The authors recommend FDA-authorized products only, not illicit market products.
What about dual use? The concern that patients end up both smoking and vaping, getting the worst of both worlds.
The guidance is explicit on this. The goal is complete substitution. Patients should work towards switching entirely from cigarettes to e-cigarettes as quickly as possible, not long-term dual use, and behavioral counseling should accompany any pharmacological approach. The quit line remains a critical resource.
For an Australian GP hearing this, the practical reality is that prescribing e-cigarettes here involves navigating the TGA's authorization pathway. It is not straightforward.
Correct. But the paradigm shift in this paper matters regardless of jurisdiction. It says to clinicians, stop treating e-cigarettes as a moral failing or a gateway drug. Start treating them as a legitimate harm reduction tool for adults who have failed other methods. Correct the misperception that nicotine causes cancer. It is the combustion products that kill, not nicotine itself. That single fact changes the conversation with patients.
Quick hits before we wrap. First, PBS, September 1st brand deletions, Amoxil capsules, Cardizom CD, Actos Polyvisc, all being removed. Generics remain available. Transition your patients. Second, TGA product information safety updates published August 10th. Check the TGA website for the full list. Third, the corpuls defibrillator suspension. TGA has suspended the Corpus 3 and 3T defibrillators. NSW, SA, and WA ambulances are still using them during the suspension period, but 117 adverse events reported since 2022, including 5 deaths. If you work in emergency medicine or retrieval, be aware.
Let us recap. 1. Semaglutide pooled kidney analysis, 16% reduction in major kidney outcomes across the cardio-kidney metabolic spectrum. AU led by Perkovich at the George Institute, strengthens the case for GLP-1 receptor agonists as kidney protective agents. 2. Nalbuphine for IPF cough, 53 to 60% cough reduction in 6 weeks. First effective pharmacological treatment for IPF cough. Phase 3 pending. 3. Seminal microbiome and fertility. Seminal dysbiosis linked to 28 percentage point lower live birth rates. Observational, but reframes infertility as a couple-level microbiome question. 4. E-cigarette clinical guidance. Include nicotine e-cigarettes in smoking cessation conversations with adults. Harm reduction over abstinence only. Complete switching is the goal.
4 papers, 4 different domains, all practice relevant. The semaglutide kidney data is the headline. That is the one you take to your next practice meeting.
See you tomorrow. Stay sharp.